Thank you very much, Dr. Hawar, for moderating the session, and thank you all the panelists. I would quickly request all the panelists for the next session. Uh, Dr. Ali Raza, if they are here, Dr. Abu Bakr Sheikh, Dr. Tayyib Moyuddin, Dr. Shabir Ahmad, Dr. Shahid Abbas, and Dr. Abdul Samad. I would also like if Dr. Hakim can come to the podium as well. And online we have, I think, Dr. Najib Azam is still sitting there. Dr. Imad Shaiban, welcome from Italy. Dr. Afsar Raza from UK. And we have Dr. Cheem still there. Thank you so much for staying there. We'll be just getting your talk quickly so that you can leave after that. And Dr. Haitham Amin is also there from Kuwait. So thank you very much, everyone. Dr. Fahim is already there. We really appreciate staying that long. So we are going to move on. I'm going to do the first talk. Actually, is Dr. Muhammad Mahdi, and sorry I have to do him first because he has been up. It's like 1 a.m. in US, so he's still awake and waiting for us. So we'll have his talk, and then we'll have Dr. Cheem and then Dr. Shaiban. So if you don't mind, I had to change a little bit, but we are going to move on to the talks. So Dr. Muhammad Mahdi Ansari, he is a great interventional cardiologist, peripheral interventionist, as well as structural interventionist, and a great academician from US. So he has given a couple of talks in our peripheral session, and now he's going to be giving a talk here on clinical decision making based on coronary physiology. Where do we stand in 2023? Dr. Ansari, are you there? Yes. Thank you very much for staying that late. You have to unmute yourself.
Thank you very much. Assalamualaikum.
Can you all hear me? You have 10 minutes, please.
Yes. Can you all hear me?
Yes, we can hear you and we can see your slides as well.
All right, thank you very much.
Change to slides.
No, Assalamualaikum, I really appreciate because unfortunately I'm on call, but I have somebody covering me. And since like last 1 hour, that person is really after me so I can return. He thinks I'm having some good time, but it is good time. Thank you very much for the invitation. So this is a very interesting topic, and what I was assigned to talk about was actually the physiologic assessment of coronary artery disease. So these are my disclosures. So basically, when we talk about physiologic assessment, I was asked to talk about if I can generalize everything in 10 minutes on the very basic things that everybody is actually looking for nowadays. And the issue is this, that when you go into the literature, there are plenty of trials, some important, some less important, and some giving us, which really helps out for us to score everything within the parameters of the guideline. So historically, the clinical significance has always been evaluated by an angiogram, as we know. And when we talk about angiography, the accuracy is limited to limitations because it's just 2D imaging, eccentric stenosis, foreshortening, and the variation in the size and the territory supplied. The overlap causes trouble, the ability to be accurately interpret the impact. These are the things that we look into whenever we have issues onto that. So in 2021, the ACC-AHA guidelines class 1 recommendation was fractional flow reserve or instantaneous wave-free ratio. So what we say about FFR and IFR. And the famous comment in that relationship was the decision maker to proceed with PCI is angiographically intermediate stenosis. And that was what came across with all the guidelines and taken into consideration for our thing. The most important aspect was what the Ohm law interpretation came. When we talk about coronary hemodynamics, they talk about coronary blood flow equal to the pressure difference with the radius of the vessel or the diameter of the vessel, which actually is dependent on the flow separation, causing these intricate currents and going towards the microcirculation. And this is the basis, the Ohm's law became the basis of all these physiological assessment, which takes into consideration not only just the flow, but the current and the flow separation on the imperial law, like discussed. And taking this, we came up with our equations of using the Doppler wire, where we measure the difference across the coronaries, where we talk about the distal coronary pressure upon the proximal coronary pressures, the PD and the PA, which on different screens and different subsets we see. And FFR, according to the initial subset that came, was we have to take into less than 0.75, and then multiple studies were incorporated to coming up with the final decision of 0.8, which was considered to be abnormal. And actually, at University of Michigan last year, they did an amazing job of incorporating all the publications that are out there and all the trials that are up there to come across the validity of this number. And their conclusion came that 0.8 is a better representation, much better than the suggestive 0.82 or the 0.75 in this context. So that actually was a further confirmation of the physiological assessment that was done in this parameter. Then we talked about the instantaneous wave-free ratio. Now, this is a very interesting part because IFR is non-inferior to the FFR guided revascularization. And how we know this? Because of the Sweetheart trial and the Define Flare trials. And this graph actually very nicely interprets that wave-free period that is shown. And the conclusion towards the IFR was less than 0.89 is considered abnormal. And why these numbers are so important? Because a lot of not only payment companies and insurance companies, but when we also talk about appropriateness criteria, they take into consideration these numbers, because even slightest fluctuations, people say, why would that take into consideration? Because when all the trials were concluded, they looked at the population, they balanced out whatever figures in those populations are to come up with this number. So it's a direct number, and somebody say why there is not a range. And there is a reason, because there was also a comparison with the range on one side versus a direct number on the other side. And University of Michigan last year, when, like I said, that was a very important step they took, that they concluded that we have to go with that. So the instantaneous ratio free trial demonstrated that IFR was non-inferior, and it was also confirmed in rechecking all the meta-analysis after that. So what is coronary flow reserve? This is another topic which is very important, particularly for the microcirculation ratio. An abnormal CFR value is obtained in a stenotic artery. It does not pinpoint the exact level at which the flow is limited, that it does not have differentiate between the epicardial and the microvascular flow limitation. The two different methods of assessing CFR invasively are available, which is actually Doppler and thermodilation. And CFR is equal to hyperemia upon the Q hyperemia versus Q basal, which is a mean transit time upon the mean transit time basal, differentiating the hyperemia divided by the basal. So the resistance in this, which is equal to the difference in the pressure divided by the coronary blood flow, because since flow is equal to 1 upon mean of the transit time of the hyperemia, and our resistance is equal to pressure into mean transit time. So in the end, when you bylaw the resistance to pressure into Doppler flow velocity, that's when you will get your value. But there are a lot of questions upon the accuracy of these. Still in many labs in the United States, this is being studied and being done on patients, but not in accordance, because when you look for these things, the convenience factor come into play, because a lot of these patients with just better medical management, the question is, you can take care of such entities unless the patient has severely reduced ejection fraction. That's when you worry about these patients. These are the cases that are become cumbersome in the sense with the timeline that it takes in the cath lab. And the question is, with the busy labs, how convenient does it play for us to go on and measuring these? Now, individual patient-wise, it does make a big difference, but in a busy center like us, it does become cumbersome when you necessitate the flow volume in the cath lab on a daily basis. I will leave you guys in the end with two important things. One is this, again, picked up from the same paper that I was related to, which actually combines very nice graphic analysis. When I looked at paper throughout for this presentation, because I was asked to sum up, this actually shows really nicely the CFR greater than 2.5 and less than 2.5, the difference between normal coronary artery and the normal with CMD, particularly looking at the effect of IMR less than 25 in the distal versus FFR greater than 0.8. And when you compare this with the stenotic range, it tells you what values you want to index it to. So just to sum up this entire thing, like I said, the normal values, want to remember, FFR greater than 0.8, CFR greater than or equal to 2.5, IMR less than 25. These are the values. There's no range in that. This is a definitive value according to the all appropriateness criteria, as according as well with all the payment plans people come up with or insurances come up with, which look into whether we're following the appropriateness criteria or not. In the end, the last thing that I really, really want to talk about, which is a very promising entity being done nowadays and also for the future, is the non-invasive coronary CT angiography when we talk about coronary physiology. This is where a lot of people are referring to. There are reports of a lot of cath labs over here decreasing their flow as much as down to 30 to 35%. So a big question mark also comes at multiple centers do not want to adopt to that, thinking that it might bring the coronary volume down because of the payment plan. But what it does is, if you look at those that adopted this technology versus those that did not adopt this technology, the comparative ratio between stress ending up with PCI versus CT angio ending up with PCI, the specificity and the sensitivity is higher as compared to that. It's an ongoing study. We wait for that. The next trial did show that FFRCT has higher specificity and comparable sensitivity. And so the 2021 AHA, ACC, ASA chest, as well as SCT and SMR guidelines clearly stated the CCTA for intermediate risk patients with acute stable chest pain class 1 indication. When we talk about FFR, CT in 40 to 90% coronary stenosis was class 2A, and invasive coronary angiogram, if FFR CT is less than 0 or less than or equal to 0.8, what class 1. So these are important entities because it's a promising future. And actually the multi-center study that was done, which actually showed 254 patients when we talk about coronary CT, they were referred for invasive coronary angiography for suspected coronary artery disease. Pre-angiography, the CCTA was performed with FRCT, and what they saw that the results were comparative to the invasive FFR as the gold standard. Sensitivity of FRCT for the diagnosis of myocardial ischemia was comparable to CCTA alone. So, and the difference was on one side 79% versus 34%, which is absolutely significant. Thank you very much. If there's any questions, I welcome that. But my conclusion in this entire thing is there's a big question mark comes towards which direction to go and whether we want to still look at the range. So these are definitive numbers that needs to be followed. There's no range goal into this. And yes, when we talk about looking at the future in this direction, like they talk about on colonoscopy and the GI thing, when the invasive thing would come in, the argument is you still need to study the physiology because anatomy itself will not give you the answer. And that's the answer for many patients that does have lesions, and with proper medical management, they do good well. So I'm an interventionist, and I say that just to lay the emphasis how coronary physiology is important and plays a vital part, and we need to do a better job in assessing them in order to make a decision of treatment modalities in these patients.
Thank you.
Thank you very much.
Mahdi, thank you very much for staying up that late and giving this talk. Great overview of coronary physiology.